I'm going to ask my questions of Mr. Hackbarth, but not because what you said is not important, Mr. Levinson. I think this whole issue of enforcement and fraud and abuse is really crucial. But yesterday, Mr. Hackbarth, I asked basically the same question of Secretary Sebelius. In other words, you know, on the one hand, we're talking about reductions in payments for certain Medicare and Medicaid programs. On the other hand, we're talking about enhancements and, you know, actually spending more on other aspects of Medicare and Medicaid. For example, Medicare Part D, filling up the donut hole. And you do both. In other words, my understanding is that, you know, your recommendations, which many of which are incorporated in this discussion draft, accomplish both purposes. So what I wanted to do, though, is I think there's more media attention on cuts than there is on what you do to enhance programs. So I wanted you to talk a little bit about what motivates MedPAC to propose some of the reductions we're contemplating, you know, like the Medicare Advantage, the home health rebasing, productivity into payment updates, and the rest. But why is it that MedPAC sees these as important policy proposals on their own terms, not because of, you know, cost savings?
Mm-hmm. Well, Mr. Chairman, we believe that pressure on the prices in the Medicare payment system is important to force the system towards more efficiency. As you and the other members of the committee know, Medicare has administered price systems that are set through a government process as opposed to market prices. We believe that what we have to do with that administered price system is mimic, so far as possible, the sort of pressure that exists in a competitive marketplace. The taxpayers who finance the Medicare program face relentless pressure, often from international competition, for example, forcing the firms that they work for to lower their costs day in and day out. We think the healthcare system must experience the same sort of pressure.
And then the solvency of the trust fund is extended and premiums were reduced and the program is maintained for future generations. So that's the ultimate goal.
Absolutely.
And let me ask you another question about, you know, we get this argument from some, and not too many, but some employers and providers complain about alleged cost shifting from Medicare to the private sector. The argument is like something like if Medicare would pay more, private plans could pay less, and so health care would be cheaper for employers and others. I don't understand how increasing Medicare payment rates would lead a private hospital to decrease the prices it charges private insurers. And can you explain this to me? You know, I mean, I know I'm asking you the opposite of what you believe, but I mean, what?
Yeah, well, let me start by saying that we believe that Medicare payment rates are adequate. We don't believe that they're too low. We don't believe that they should be increased. And let me focus on hospital services as an example of that. We look at the data in several different ways. We've looked at time series data, and you see there's a pretty consistent relationship. In periods where private payments are generous, Medicare margins become negative. And it's our belief that that's because when the private payments are generous, hospitals have more money to spend, and they spend it. It's a largely not-for-profit industry. If they get revenue, they will spend it. And then we see the same pattern when we look at individual hospitals. So what we've identified is a group of hospitals that don't have a lot of generous payment from private payers. They have constrained resources. Those institutions lower their costs and actually have a positive margin on Medicare business. They don't have the luxury of additional private money flowing into their institutions. They're forced to control costs, and they do control costs as a result.
And so you disagree with claims that Medicare is responsible for high health insurance premiums?
No. If institutions, clearly the rates paid by Medicare and private payers are different. Private payers pay higher rates. It does not follow from that, however, if you increase Medicare rates, that the private rates would fall.
Okay. And let me just one more thing about access. You know, we hear about in some parts of the country that, you know, Medicare enrollees say that they can't find a doctor willing to accept new patients. Based on your research, do you have any reason to believe that we have a crisis of access in Medicare, that basically providers are not taking Medicare in a significant way?
Each year we do a careful study of access for Medicare beneficiaries, asking both patients and physicians. Our most recent patient survey, which was done in the fall of 2008, found that Medicare beneficiaries are more satisfied with their access to care than private patients, privately insured patients in the 50 to 64 age group. The one area of concern that we do have is around access to primary care services, especially for Medicare beneficiaries looking for a new physician, for example, because they've moved. That's the area where we see Medicare beneficiaries reporting the most problem. But we also see privately insured patients in the same circumstance reporting problems as well. So we don't think the issue is a function of Medicare payment rates, but rather too few primary care physicians.
Which was one of the things we're trying to address in this discussion draft. Thank you. Mr. Deal?
Mr. Hackbart, let me follow up on one of your comments about your look at those hospitals that have higher ratios of Medicare patients and lower ratios of private pay patients. And I believe your statement was that they are able to make a profit and in fact be more profitable than some of the ones who have lower volume of Medicare patients. Don't those hospitals receive dish payments as a general rule?
Some of them may, yeah.
Does your recommendation in any way address whether dish payments should continue or be abolished?
We have had some discussion, Mr. Deal, about refocusing dish payments. We have not recommended abolishing them.
Okay. Mr. Levinson, the draft talks about expanding Medicaid coverage and providing federal payment of 100% for some of this expansion of new populations so that the states don't have to pick up even their matching share in their Medicaid formula. If that is the case, if the federal government picks up 100% of this cost, are you concerned that states will no longer have the incentive to look for the waste and the fraud and the abuse because they don't really have any state dollars in that pot? Is that a concern from your standpoint?
Well, it is certainly always a concern about what is occurring with the federal share of Medicaid, and indeed, as we look for a larger share of that on the federal side, it becomes of greater interest to us at the federal level. It's an issue, actually, that I, as a member of the Recovery Act Accountability and Transparency Board, is already dealing with my colleagues on the board, because the ARA does include a significant increase in the federal share funding to alleviate states of some of the Medicaid burden. And in some of the states, particularly in the south central part of the United States, we are approaching a level where states give little, if any, contribution to Medicaid. So we are focusing on ensuring that there are controls in place to make sure that the Medicaid dollar is protected. But as the federal involvement becomes greater, the need for more federal monitoring of those dollars also becomes greater.
Because the states have been the primary enforcement, first line of enforcement against fraud and abuse with oversight from the federal. So you're saying that there may be a need for more federal oversight?
That is correct. Historically, the Medicaid fraud control units, which exist in nearly every state of the union, have been really the first protectors, as it is, of the Medicaid program. We have provided oversight. In the last several years, though, Congress has provided us additional funding to be more involved in the monitoring of those Medicaid dollars as the federal share has increased.
Mr. Hackbart, in your testimony, you make reference, I think, to the fact that about 60% of beneficiaries now buy supplemental policies to cover part of their Medicare cost. That seems to me a little bit inconsistent with your conclusion that the Medicare reimbursement rates are adequate. I know one is from the provider standpoint and the other being from the patient standpoint. Do you foresee from the patient standpoint that if we model everything after the Medicare reimbursement rates and the Medicare model, that there's going to be a need for even more purchasing of supplemental insurance by individual patients?
Well, as you say, Mr. Deal, there are two distinct issues. One is the adequacy of payment rates to providers, and we believe those payment rates are adequate. The Medicare benefit package is probably not designed the way any of us would design it if we were starting with a clean piece of paper. The design could be streamlined, and that process may reduce the need for beneficiaries to buy supplemental coverage. For example, if we were to add catastrophic coverage, a key missing component of Medicare, that might reduce the perceived need for supplemental coverage.
Okay.
We've begun looking at that redesign issue.
Real quickly, you were going through your principles that you have recommended, and you got through most of them, I think. In the very short time that I have left, are there any of those principles that you are concerned that are not being addressed in this discussion draft, in particular, any that you have great concern about?
Off the top of my head, Mr. Deal, I can't think of one.
Okay. Thank you, Mr. Chairman.
The chair now recognizes Mr. Murphy for his questions.
Thank you very much, Madam Chair. And Mr. Hackbarth, thank you so much for all the work that you've done guiding this Congress on this issue of moving away from a volume-based system to a system that attempts to really reward outcome and performance. And I think I, for one, am worried that if we don't take advantage of this moment in time with this healthcare reform debate to make those changes, that we may never be able to make them. And so I know Mr. Deal just asked you a general question about whether there were points of reform that you've pushed that aren't in this bill, but I wanted to ask specifically on this issue of payment reform. Mm-hmm. Have you taken a look at this bill with regard to payment reform, and how do you think it measures up versus what you think could be potentially done through this Reform Act with regard to transforming our payment system?
Yeah. Well, as I indicated to Mr. Deal, I think that the bill's provisions on Medicare are pretty comprehensive and address the major issues that MedPAC has raised about the Medicare program. Having said that, some of the provisions, let me take an example, accountable care organizations or bundling. You know, the bill provides for pilots of these new ideas, and in fact that's what MedPAC has recommended. These are complex ideas that will take time to develop and refine. So the bill includes provisions. We shouldn't assume from that, oh, it's a done deal. There's lots of work that needs to be done in CMS in particular to make these things a reality.
Well, and that was going to be my second question. You've had a lot of experience in pilot programs, right. And I think one of the things that some of us worry about is that that there has been a lot of research done on, for instance, the issue of accountable care organizations and bundling, and I think the majority of evidence is that they work, that they get good outcomes and they can reduce costs. And so if we are going to go into a bill that pilots these, how do we make sure that if the pilots turn up with the outcomes that pretty much every other, all other work on these payment reforms have done, how do we make sure that then that becomes a system-wide reform?
Yes, this is an issue that I think we discussed last time I was with the committee. The pace at which we make changes, reform the Medicare payment systems is way too slow. And one of the things that we've recommended is a broader use of pilots as opposed to demonstrations. And the difference in our mind is that under a pilot, the Secretary has the authority to move to implementation if the pilot achieves stated objectives. It doesn't have to come back through the legislative process. We think that's a very important step. And again, I'd emphasize CMS needs more resources to do these things both quickly and effectively. They're operating on a shoestring, and the work is too important, too complex to allow that to continue.
And let me ask then specifically about this issue of accountable care organizations. it seems to me that one of the ways that you expand out to a system of outcome-based performance is that you try to encourage physicians to join in and collaborate. Right. We've put an enormous amount of money in the stimulus bill into giving physicians and hospitals the information technology to create those interactions and that coordination. I guess I'd ask you, what are the ways that we need to be looking at in order to try to provide some real incentives for physicians to coordinate, become part of multi-specialty groups, enter into cooperative agreements? And then should we be looking at only incentives, or should we be looking at something tougher than incentives to try to move more quickly to a system by which physicians aren't operating in their own independent silos?
Yeah. Well, the fact that we have a fragmented delivery system, I believe, is the result of how we've paid for medical care, not just in Medicare, but also in private insurance programs for so many years. We basically enable this sort of siloed, independent practice without coordination. The most important step we can take is change the payment systems so that services are bundled together, and physicians of various specialties and various types of providers must work together. And there's abundant evidence that when they do that, we not only get lower costs, we get better quality.
Very much, Madam Chair.
Thank you. The chair now recognizes Congressman Burgess for his questions.
Thank you, Madam Chair. Mr. Akbar, it's always good to see you. And I have several questions that I'm going to submit in writing because time is so short during these Q&As. And I was going to reserve all my questions, in fact, for the Inspector General, but I just have to pick up on a point that was just expressed. And under the Accountable Care Organization, within Medicare, just within the Medicare system, with Medicare being an entirely federal system, it is not a state system, it is a federal system. So we don't have state mandates in Medicare. It functions across state lines. If we were to provide an incentive that is a backstop on liability under the Federal Tort Claims Act for doctors practicing within the Medicare system who practice under the guidelines of whatever we decide the Accountable Care Organization, the proper Accountable Care Organization should be, would that not be the type of incentive that we could offer to physicians that would not require increase in payments, but yet would bring doctors increase their interest in practicing within these accountable care organizations?
Yeah. Dr. Burgess, MedPAC has not looked specifically at the malpractice issue. We principally focus on federal issues. That's our
But if I could, we could make liability a federal issue within the Medicare system, because defensive medicine does cost the federal system additional dollars, as Dr. McClellan's great article from 1996 showed.
Right. And my point is that there's no MedPAC position on malpractice issues. As you know, though, I am formerly a CEO of a very large medical group, so I have a lot of experience working with physicians, and I know how large malpractice looms in the minds of physicians. Because they've not studied the issue in detail, I don't have a specific recommendation, but I think addressing physician concerns about malpractice is a reasonable thing to do. That's
well, one of the things that really bothers me about these discussions in this committee, you have so many people here who have never run a medical practice as you have, and as some of us have. Doctors tend to be very goal-directed individuals. That is why the fee-for-service system has worked for so long, because you tell us what to do and what the rules are, and we make a living at it. I'm not a big fan of bundling. I don't trust hospital administrators as a general rule, and I would not trust them to appropriately apportion out the payments. So not a big fan there, but there ought to be other ways to tap into the goal-directed nature of America's physicians to achieve the goals that you're trying to get. And right now, I don't think, at least from what I've seen, we're quite there. I'm going to actually go to Mr. Levinson, because what you have talked about is so terribly important. And let me just ask a question. Right now, within the discussion draft we're talking about, I don't think the numbers are filled in as far as the budget, the numbers, the dollar numbers that are going to be there. What do you need today in order to do your job more effectively?
While we certainly need the resources that we have been given by the Congress and by the executive, and it is certainly being used, I think, in an optimum way. But as the mission gets larger, the need for greater resources also is there.
And I'm going to interrupt you. That's an extremely important point, because we've increased the FMAP and so in the stimulus bill and some of the other things that we're talking about doing. Is that not going to increase the burden, the pressure that's placed on you and your organization in order to provide the proper oversight?
Certainly, our mission has been heading north for the last few years, and we are really pressed to enlist really the best investigators, evaluators, lawyers, and auditors we can find to handle a much larger budget than historically we ever have had before.
And it's not just you, because my understanding from talking to folks back home in the Dallas-Fort Worth area, from within the HHS Inspector General's shop and within the Department of Justice's jurisdiction, there's actually a deficit of prosecutorial assets, or actually assets have been had to use for other things, Homeland Security, narcotics trafficking, and there's not the prosecutors to devote to the cases that you all develop to bring those cases to trial.
That's a very important point, and sometimes it's overlooked how key it is to understand that the resources that are used to fight healthcare fraud really require a collaborative effort across several different government entities. And if you have the Justice Department personnel but don't have the IG personnel, and vice versa, you really have a significant problem.
And just one last point, I will submit several questions in writing on the issue that we're hearing so much about in McAllen, Texas, where the McAllen appears to be an outlier. Many physicians from the Texas border area were in town yesterday. I don't represent the border area, but they discussed it with me. They are concerned, obviously, about the negative press that they have been getting over the report by Dr. Gwande in the New Yorker magazine. Is there any special focus that you are putting on that area because of the possibility of diversion of Medicare, Medicaid dollars within other ancillary agencies, imaging, drugs, home health? Is the possibility that this number is skewed not because of practitioners in the area, but because, in fact, that we don't have the resources to devote to the investigation of the fraud, the prosecution of the fraud when it's uncovered?
Well, there are a number of high-profile areas that we oversee that we do need to concentrate on, because they do tend to be areas where fraud, waste, and abuse tends to become a lot more serious than perhaps others. The durable medical equipment area, for example, especially in South Florida, has triggered our need to develop a strike force that's specifically devoted to trying to uncover and, to the extent possible, eliminate DME fraud in South Florida. We've had very good results there, actually, in being able to clean up many of the problem areas. I can point to other parts of the country where other kinds of issues have arisen that really require a concentrated effort by us, working with our law enforcement partners. I can't speak specifically to McAllen, Texas.
Is that on your radar screen to pull that into the investigative process?
I can only say that the entire nation is on our screen because we have such an extensive jurisdictional requirement.
All right. Thank you, Mr. Chairman.
The chair now recognizes Mr. Green for his questions.
Thank you. Mr. Hackworth, in your testimony, you cited a lack of care coordination and a lack of incentive for providers to actually coordinate care as a cost burden. And I agree, and we have several coordination bills pending before our committee. One is a Realigning Care Act, which focuses on geriatric care coordination. Your testimony cites geriatrics as an area in which care coordination is especially necessary. Can you elaborate on how geriatric care coordination can help lower health care costs? And again, we're dealing with Medicare, but maybe we could also deal with whatever we create in the national health care.
Yeah. Geriatricians, as you know, tend to focus on elderly patients who have very complex, multiple illnesses. And for those patients, not only is the potential for inappropriate, unnecessary care large, the risk to the patient of uncoordinated care is very large indeed. And so such patients really need somebody who's going to follow them at each step, not hand them off to specialists and then they're handed to another specialist and another. They need somebody as that home base to integrate and coordinate the services.
And I know that's our goal, is to talk about a medical home where someone can do it. Any of us, a number of us had elderly parents who we've had to monitor the number of doctor's visits simply because they also take lots of different medications that there's nobody coordinating that except maybe a family member.
And the problem is, as you well know, Mr. Green, is that Medicare really doesn't pay for that activity outside of the patient visit. The phone calls that need to be made to pull together the services so that they're well integrated. So we made a series of recommendations to increase payment for primary care and the medical home, which in addition to the fee-based payments has a per-patient sum to support that sort of activity.
And since we're also concerned about the scoring, did MedPAC look at, by creating this benefit of coordinated care, could we save on the back end? Is there something we could quantify, say, to CBO, or someone could say, we, over a period of time, we think we can save ultimately?
Yeah, well, it's our hope and perhaps even our expectation that there would be savings. But what we've recommended and what the Congress has done is a large-scale pilot so that, in fact, we can hopefully document those savings and to have a resulting CBO score from it.
Okay. And I know we have your, under current law, we have your Welcome to Medicare exam. Do you think that could fit in there with what we would call a geriatric assessment initially and then build on using that primary care?
Well, potentially, because it gives the physician, hopefully a strong primary care physician, an introductory assessment of all of the patient's problems right from the outset.
Okay. And again, I know there's a provision in the bill, and a lot of us have that interest, and that's one of the good things about this bill that we're dealing with. But again, since we're looking at scoring, say, you know, and it's hard to get CBO to say at the end we can save money. Not only save money, but almost much more humane dealing with Medicare or any patient, in all honesty.
What I can say, Mr. Green, is that, as I said in my opening comment, there's abundant evidence that systems that have strong primary care have lower costs and higher quality than systems that don't have strong primary care. You see that in international comparisons. You see that in studies within the United States that compare regions with one another. You see that within health systems. So there is lots of evidence of that sort. Whether CBO considers that strong enough to score is a CBO issue, not a med.
Maybe by your testimony we can encourage CBO to look at other countries that have a primary care emphasis and how that can reduce the cost. So maybe the bean counters can actually say this works. And so I appreciate your testimony, and hopefully we'll get that in our response when we get that score. So thank you. Madam Chairman, I yield back my time.
Congressman Gingrey is now recognized.
Madam Chairman, thank you, and I'm going to direct my questions to Mr. Hackbarth. Mr. Hackbarth, among the barriers to achieving value in Medicare cited in your testimony, you state that Medicare payment policies ought to, quote, ought to exert fiscal pressure on providers. Mm-hmm. You go on to state that in a fully competitive market, which I'm guessing infers that Medicare does not compete in a fully competitive market, that this fiscal pressure happens automatically in a fully competitive market. In the absence of such a competitive market, you suggest that Congress must exert this pressure by limiting payment updates to Medicare physician updates. When creating Medicare Part D, Congress considered instituting a set payment rate in lieu of creating a competitive market where competition among the pharmacy benefit plans might automatically keep the cost down. In the end, this Congress elected to go with that competitive model and forego payment rates set in statute similar to those that exist under current Medicare fee-for-service. The results, as we all now know, is that due to the private market pressure rather than government price setting, Part D premiums are much lower than anticipated, and drug prices have gone down. So instead of exerting the fiscal pressure on providers that you suggest must be exerted due to the lack of a competitive market to do it automatically, I'm curious as to your thoughts on how using a competitive bidding process like what we did in Medicare Part D might achieve the same sort of efficiencies you suggest are required in traditional Medicare, but without having to resort to restricting the payments.
Mm-hmm. Well, let me approach it from two directions, Dr. Gingrey. If we look at private insurers in the private insurance marketplace, and we compare the costs of those programs with Medicare costs, what we see is that on average, and my evidence here is from the Medicare Advantage program, is that the bids submitted by the private plans are higher than Medicare's costs. They're not lower. Now, there are some plans that bid lower, but on average, the private bids are higher. So that's an opportunity for private plans to come in and compete and show that they can reduce costs, and by their own bids, they have not done that.
You're talking Medicare Advantage.
Medicare Advantage.
But of course, Ms. Hackworth, they do provide something that these three committees that have come up with this draft legislation, if you will, really want, and that is, of course, emphasis on things other than just episodic care, treatment of pain and suffering, but also wellness prevention and that sort of thing.
Yeah, some do, some don't. Yeah. The private plans are quite variable in their structure, how they deal with providers, what sort of care coordination programs they have, and most importantly, they're quite variable in their bottom line results. Some are outstanding, some are not.
Yeah. Let me go on to another question. I thank you for that response. One of the foundations of your testimony today is that the American healthcare system has serious quality problems. You quote, at the same time that Americans are not receiving enough of the recommended care, the care they are receiving may not be appropriate, end of quote. And then you go on to cite the Dartmouth Center for the Evaluative Clinical Services as proof of a wide variation in Medicare spending and rates of service use. Just to be clear, when you say the American system, Mr. Hackbarth, are you referring to the American Medicare system and not the entire American healthcare system? Am I correct in that assumption, given that the Dartmouth study used only Medicare data to support its findings? We're talking about the American Medicare system and not the entire healthcare system.
Well, in fact, the Dartmouth study is done using Medicare data because it's the most readily available comprehensive database. I don't think there's any reason to believe that physicians are practicing different for Medicare patients and private patients. In fact, my own personal experience in working closely with physicians is that it's a matter of principle that they don't vary their care based on the insurance coverage of the patient. They treat the patient based on what the patient needs. So I think it's a reasonable inference. If you see this variation in Medicare, you're likely to have the same variation.
Well, I know my time is up, Madam Chairman, but the reason I ask you this question, Mr. Hackbarth, because we're going to have another panel, probably several more panels today, but I think there are going to be some physicians that are practicing in the private market that might want to dispute what you just said. But thank you so much for your response, and I yield back, Madam Chairman.
Thank you. I now yield myself my time for questions, and I thank you both for your testimony today. Mr. Hackbarth, we're sort of picking on you, I think, but you can tell from the questions that Medicare payment reform seems to be a very pressing issue for many of us. And one of the Medicare payment reforms we're suggesting in this legislation is a change to the GPCI formula in California so that it is now based on MSAs, the Metropolitan Statistical Area. 2 of the counties I represent in California are negatively impacted by the current payment formula. Physicians in both San Luis Obispo and Santa Barbara counties are paid less, much less, they would say, than the actual cost of practicing medicine. My question to you is in general, but also specifically toward California. Will the GPCI provisions improve the accuracy of payments in the new fee schedule areas that you, across the country, as you have envision them?
Yeah, the provision related to California in the bill is based on one of 2 options that MedPAC developed for CMS back in, I think it was 2007. So the approach in the bill is consistent with the advice that we've given CMS.
Excellent. And then maybe you could elaborate a little bit on the benefit, obviously, that you are seeing from having physician payment areas aligned with hospital payment areas. And is that, again, consistent around the nation once we get our alignment correct in California?
Well, the issue that we focused on was specific to California. As you know, the GPCIs work differently in different states. And so our recommendation wasn't that this approach be applied everywhere, but we saw it as a reasonable solution to the California issues that you and other members have raised.
Now, we have seen that other areas of the country have this disparity as well, but do you think those are best resolved on a regional basis?
Yeah, different states have elected to resolve it differently, and we think the problems are not national in scope, but more isolated, and more tailored approaches are the best way to go.
And that would be a pattern that you might suggest in other areas as well, that we look at regional issues, particularly at least in the payment schedules?
Yeah, well, you know, that's a big statement, and I'd want
well, I'm
to
just wanting to see how far you want to go.
Yeah, I'd like to take a look at, consider the issues one by one, as opposed to make that as a broad policy statement.
Well, I know my California colleagues, this has been a real serious detriment to Medicare in the practice of Medicare in our state. In many of the regions, that the cost of living has been very different from what the allotment has been. So this becomes for us a really vital component of Medicare reform. Under this bill.
And as I say, we think the approach in the bill is a reasonable one, and it's one of the options that we recommended to CMS.
Okay, I'm going to yield back my time. And recognize Mr. Bouyer for his questions.
See a company in Tampa just shut their doors to 500 jobs due to the SCHIP bill. They're going to send the tobacco, those cigars to be made offshore. Just thought I'd let everybody know. Who really cares, I guess. This has been a challenge to get my arms around this in a short period of time. Just to be very honest with you. So I'm trying to understand. I just went through that tobacco bill where the majority froze the market. So they love this talk about competition, and they love to freeze the market in place. And I'm getting a sense that that's what you're doing in this bill also. You freeze the market. So those of whom have existing plans, you freeze it, grandfather it, and then you got to figure out how you move people into the exchange. And if you, and when we freeze that market, so help me here with my logic. I'm trying to figure out what you're trying to do. We freeze that market, and you want to move a population into an exchange. You can grandfather so people can keep their existing coverage. But if at some point in time that employee chooses to move to a government plan, then the employer has to pay an 8% tax on it. Is that right?
Is that correct?
Yes.
Mr. Byer?
Pronounced Booyer.
Booyer, I'm sorry.
Okay.
Our focus is on the Medicare provisions of the bill. And the bill is not our bill. We are advisory
Okay, so
body.
you can't answer that question.
Absolutely not. That's beyond our jurisdiction.
No, that's okay. Well, let me ask a question that is within your jurisdiction. You had, sir, you had suggested that encouraging the use of comparative effectiveness information would facilitate informed decisions by providers and patients about alternative services for diagnosing and treatment of most common clinical conditions. Is that correct?
Mm-hmm.
Means yes?
Yes, sir.
Thank you. Following your line of reasoning, could the Medicare program also use this research to exert fiscal pressure on drug and device makers or even restrict certain procedures based solely on price?
What MedPAC has recommended is that the federal government invest in comparative effectiveness research, make it available to physicians, patients, insurers, for them to make their own decisions about how to use the information.
Then how best do we, i.e. Congress, how best do we make sure that this research is used to inform the consumer and providers without being an excuse to exclude or ration certain types of care? How do we best do that?
Well, decisions about how Medicare would use the information are issues on which Congress can legislate. What MedPAC has recommended is investment in information to be used in a decentralized way by all of the participants in the system.
All right. Mr. Levinson, one of the great concerns I have is, would you be able to address a comparison or analogy on Medicaid? I know you're Medicare. You guys are claiming lanes of jurisdiction here.
Mr. Booyer, we actually, as an Office of Inspector General, we oversee all 300 programs of the department. So we also have important oversight of Medicaid.
All right, thank you. So most of the fraud cases with regard to Medicaid, are they discovered by the states or are they discovered by the federal government?
Medicaid cases can be developed along a very wide spectrum of possible sources.
I understand, but are most cases discovered in the states or by the federal government?
I would have to find out those numbers for you. I suspect it would be mostly states in terms of absolute number, but in terms of dollars, because some of the biggest.
All right, don't do it by dollars. You do it by cases.
By the number of cases.
I think common sense tells us. Let me jump ahead.
Given the Medicaid fraud control.
I think common sense is going to tell us that if states have a stake in the game, that they have an incentive then to make sure they go after fraud cases. If federal government picks that up at 100%, my concern is, are we disincentivizing states with its oversight responsibility, which places more on you? And is that a concern to you?
It is certainly a very important concern that we make sure that every Medicaid dollar, and we of course have responsibility for the federal share of that Medicaid, is accounted for as much as possible. And as the federal share, as the FMAP goes north, goes up, obviously our reach needs to be greater, our concern needs to be elevated on the Medicaid side. Absolutely.
Thank you. The gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman. Mr. Levinson, to follow up on that point, all of us on this subcommittee are strongly opposed to fraud in any healthcare delivery system. So let's start with that premise. I think the real elephant in the room is that fraud is a small component of what the real obstacle is to meaningful healthcare reform, and that's waste. Because according to many reliable projections, there's $700 billion annually of waste in Medicare delivery. which is a much greater problem, because if you take that number and multiply it over the 10-year period of this health care bill we're talking about, you're talking about $7 trillion of cost savings that would more than pay for the entire cost of the program we're talking about. So isn't it waste that's really the problem here?
Mr. Braley, we try to identify and correct issues of fraud, waste, and abuse, and we do not have solid figures in which to share with you exactly how that pie may be divided specifically. But all of those kinds of issues are of great concern to the office, and we have work that supports recommendations in all of those areas.
And they should be of concern to American taxpayers also.
Absolutely.
Okay. Mr. Hackbarth, I really appreciate the effort that you and MedPAC have put into this. You mentioned the objectives of health care reform being high-quality care and protecting taxpayers from undue financial burdens. And getting back to my point that I just made, under the current health care delivery system and reimbursement model, we are wasting billions of dollars every year, aren't we?
It's our belief that, yeah, we can do better with less. And there's lots of research to support that.
Well, and one of the problems that my healthcare providers in Iowa have is that for years, they consistently rank in the top 5 in every objective quality measurement and at the very bottom of Medicare reimbursement. Isn't that a summary of what's wrong with our healthcare model today?
Well, my home state of Oregon is also one.
Exactly.
With you in Iowa. And so that's a type of evidence that we can do better for less in Medicare. You know, I think it's good for Iowa and good for Oregon that we've got low health care costs and high quality. Not only does it hold down Medicare expenditures, it's good for our beneficiaries. It holds down their out-of-pocket expenses, their Medigap premiums. So I don't want to increase Iowa and Oregon to be more like some of the high-cost states.
Exactly.
I want to bring the high-cost states down to Iowa and Oregon.
And isn't that the problem? Because under Medicare's proposed pay-for-performance system, the modeling is based upon improvements in efficiency. So if you're a state like Oregon and Iowa who's already delivering efficient, low-cost, high-quality health care, you get no incentive from a model of reimbursement that's based only on improvement. Isn't that true?
Well, as we move to new payment systems, move away from our siloed fee-for-service system to bundled payment systems or ACOs, one of the critical decisions that's going to have to be addressed is how to set those initial rates for these new types of payment systems. And in that is an opportunity to address some of these regional inequity issues that have come up in the program.
But if you're going to base a public health insurance option on a Medicare model that already has built-in inefficiencies and inequities in reimbursement, what reform hope does that give to this country?
Yeah. We need to change the Medicare model, independent of the public plan issue. For Medicare's own sake, for the taxpayers' sake, for the beneficiaries' sake, we have to change the Medicare model.
Well, and I'm glad you mentioned that because Congressman Ron Kind and I have introduced the Medicare Payment Improvement Act of 2009, H.R. 2844, that attempts to do just that by identifying clear, objective quality measurements that are highly recommended by a number of healthcare organizations that are looking to improve efficiencies and increase quality. It examines things like health outcomes and health status of the Medicare population, patient safety, patient satisfaction, hospital readmission rates, hospital emergency department utilization, hospital admissions for conditions, mortality related to health care, and other items determined by HHS. Isn't it true that until we move to some transformational type of healthcare reimbursement, we are ignoring the real cost opportunities to transform healthcare and provide expanded access to coverage?
Yes. We believe that we need to adjust payment to reflect the quality of care. That's one type of change. But we also believe that we need to move away from fragmented fee-for-service payment to paying for larger bundles, paying for populations of Medicare patients. The big difference between Iowa and the high-cost states is on the utilization of services. How many hospital days per thousand, how many referrals to specialists and the like. Iowa tends to be low on those things, and the high-cost states tend to be high on those things. If we move towards a payment system that advantages places with lower utilization, like Iowa, that will begin to address these regional inequity issues that you're focused on.
Thank you.
Thank you, Mr. Braley. Mr. Shimkus.
Thank you, Mr. Chairman, and I appreciate the little comments we had before my questioning. I'm going to follow up on something I addressed last night, and addressing just the basic FMAP formula, which has been a bone of contention for me for many, many years. I believe it's been flawed and does not accurately reflect a given state's need to meet its Medicaid obligations. So that's kind of where I'm coming from. The formula does not accurately reflect the difference between a state's fiscal earnings, low-income citizens, or cost of delivery of service. This results in states like mine, and I think other states, if my colleagues would do some research, which only having a match of around 50%. We know in the testimony yesterday we had New Jersey here, we had California, they're also 50% match states, and I've got the list here where every state falls. But it falls short of its needs, yet other states have matches as high as 75%. Overall, the FMAP formula has resulted in the federal government's financing remaining around 57% across the board, yet the discussion draft seeks to have states enroll childless adults ages 19 to 64 up to 137% of poverty line and have the federal government finance 100% of this new Medicaid population. That was part of the discussion we were having offline. Do you think it's fair that we continue to have these inequities among states when it comes to FMAP, given we aren't meeting the needs of many states, especially those with low matches?
Mr. Shimkus, would you like me to respond to that question?
It's a question to both.
I would have to say that our office, not being a policy office, we don't actually establish the FMAP rates. We certainly audit those among our auditors, but we're not a program office. We oversee that. So I can't...
So as an auditing office, you wouldn't disagree with that analysis that I've given?
Well, actually, the rate is higher now in some of the states as a result of the American
yeah, and that's a good
Recovery
point.
Investment
Yeah,
Act.
that's true. But there's still percentage inequities. So you have a 75% state that's now up to 83%. You have a 50% state that's up to maybe 60%. But, of course, there's no assumption. I mean, depending upon what we do on a bill, there's no assumption that those amounts remain, because the stimulus bill was a short-term bill. And there's no certainty that that input of money will remain.
Mr. Shimkus, we work with the numbers that we're given as opposed to
Okay,
establishing the numbers ourselves.
Mr. Hackbarth?
Mr. Shimkus, we focus exclusively on Medicare issues, not Medicaid. That's our jurisdiction under the statute.
Okay, let me go with a few other questions just to put it, you know, our frustration with this process of rushing through and having a draft is we've got to ask these questions when we have to, and I want to get these out. Would it be appropriate in the context of health reform to address the inequity of FMAP by recalculating the FMAP to accurately reflect needs, or at the very least level the playing field for every state? Levinson, do you want to?
Mr. Shimkus, that's really beyond my charter.
Good, okay. Mr. Hackbarth, same answer? Yep. Okay, so what I'm trying to establish is this. Illinois is a 50-50 match state, which means that for every dollar spent on Medicaid, we will write a check to the state for 50 cents. Okay? There are states out there that for every dollar they spend on Medicaid, the federal government sends them 75 cents. If we're doing health care reform, and the premise of this bill is when we add people to Medicaid, 100% of that will be spent, but it still does not affect the basic fundamental inequity of the FMAP. So what states have to do is they have to game the system. They have to go to HHS. They have to find passed additional tax incentives to get additional rebates. We have the tax increase on beds in hospitals that we passed. So they pass a tax, they remit the tax back to the federal government. The federal government gives the tax back to them plus some additional revenue. So I would encourage folks my colleagues, to look at their FMAP percentage. And if we're going to move on streamlining health care and reimbursement, even as we increase the amount for the new Medicaid people we bring on, we really bring some clarity and equality across the state lands and FMAP. And Mr. Chairman, thank you for letting me go 13 seconds over, and I yield back my time.
Thank you. The gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman. Good morning. Good morning. Mr. Hackbarth, you state in your testimony that the payment system for Medicare Advantage plans needs reform. The Medicare Advantage program continues to be more costly than traditional Medicare health services. The Medicare Advantage government payments per enrollee are projected to be 114% of comparable fee-for-service spending in 2009. It's up from 2008. The high Medicare Advantage payments provide a signal to plans that the Medicare program is willing to pay more for the same services in Medicare Advantage than it does in traditional Medicare and fee-for-service. Our discussion draft tackles the overpayment issue. But what would happen if we did not do this?
Well, let me begin by saying that MedPAC very much supports giving Medicare beneficiaries the option to enroll in private plans. So we're enthusiastic about that. Our objections are to the current payment system, which, as you say, pays significantly more on average for private plans than it would cost traditional Medicare to pay for the same patients. If we were to lower the rate, one of the effects of that would be to send a market signal to private plans about what we want to buy as a Medicare program. And it will reward plans that take steps to be more efficient, more effective in the care that they provide. So long as we continue to pay more, the signal that we're sending is mimicking Medicare, traditional Medicare, just at a higher cost is okay with us. And so long as we send that signal, we'll get more of that. We've got to change the signal to get the market response that we desire.
And ultimately help us control costs across the board.
Absolutely. And control costs for the beneficiaries as well, because all beneficiaries, even those who aren't enrolled in private plans, are paying part of the additional costs for Medicare Advantage.
And I'm afraid these overpayments have created incentives for extensive unethical behavior by insurance companies. 3/4 of the states report marketing abuses in Medicare, and I have some firsthand experience with this talking to seniors at retirement centers in my hometown where insurance salesmen have come in, targeted seniors with dementia who were on traditional Medicare and signed them up for Medicare Advantage, sometimes under the guise of coming in and selling their Medicare Part D policies and then switching them out. And what happens is that senior who has a long-time relationship with their doctor, oftentimes they lose access to that doctor they had under traditional Medicare because their Medicare Advantage plan doesn't have the same doctor. There have been cases where cash incentives have been provided to insurance salesmen, and this shouldn't be. That we shouldn't have these incentives for fraudulent behavior. I think it's gotten out of hand, and unfortunately CMS has all but abdicated its oversight role. The Congress some years ago took the state's ability away, their ability to regulate and oversee these terrible marketing abuses. Now our discussion draft, it makes some very subtle change and with enhanced penalties for Medicare Advantage and Part D marketing violations. But don't you think we need to go back to having as robust a strike force as we possibly can, and give the states the ability, they're closer to the ground, the ability they had before to tackle the marketing abuses. The National Association of Insurance Commissioners supports such a move. Without it, unless we do this, we'll continue to have this huge regulatory gap. But what is your view?
Ms. Castor, we certainly work with the states to, as much as possible, protect the Medicare and the Medicaid programs. We have a very good collaborative relationship with our state auditors and state and local law enforcement. There are jurisdictional divides, and we try to respect those. But to the extent that we can actually understand schemes that are broader than just one particular matter, that really allows us to do our work more effectively, because the fact of the matter is although we are one of the larger Inspector General offices in government, given the size of our programs, we are very stretched. We only have a few hundred criminal investigators to handle, billions and billions of dollars stretched across the country in a variety of healthcare contexts. But I certainly would underscore the importance of being able to work very much hand in glove with our state and local partners.
Thank you. Gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman. I thank the panelists for being here. Some questions about Medicare. It was founded in 1965. In the ensuing years, has there ever been a time when any president or any Congress has really gone back and overhauled the program, and this program being established back in pre-CT scan and MRI days? Has there ever been a comprehensive overhaul of the system to modernize it, reform it, make it work more effectively?
Well, the payment systems have changed. Medicare began with payment systems that were based on cost reimbursement.
But in terms of how it functions, because today you're talking about a number of interesting reforms, and has that ever been attempted before?
Well, the payment systems have been reformed. They have changed substantially over the life of the program.
But I mean,
we think more changes are warranted.
You're talking about the other delivery, like care coordination and preventing readmissions and things like that. That's never been attempted, right? I mean, in terms of overall reforms in the system.
There has not been payment reforms focused on readmissions, no.
Okay, I'm assuming you're talking about more than just payment reforms today, because your report has a lot more than just how the money gets spent. Okay. And in that, I mean, I noted in the 110th Congress, there was 452 bills put in by members of Congress to make some reforms to Medicare and Medicaid. I think 12 passed. And some 13,000 co-sponsors of these bills came through with members of Congress. So I look upon this that members of Congress themselves recognize there needs to be some changes in Medicare and Medicaid, but it seems to come slow. I'm wondering, in this process where some of the changes you recommend here, and I applaud them because of things I've been asking for a long time too, care coordination. I mean, we'll pay to amputate the legs of a diabetic, won't pay to have some nurse call them with these cases. We recognize 1 in 5 chronic illnesses gets readmitted to the hospital. We haven't been working at keeping them out. And those are major changes to make here. Mm-hmm. My concern is the speed at which the federal government moves to make changes, number one. And two, does the federal government have to run its own insurance plan, given its track record of not being very good at coming up with timely changes? Can we come up with some of these changes with the federal government pushing for and mandating some of these changes within the private market, mm-hmm. And in the meantime, Medicare pushing some within itself? Is that possible to do that?
Well, I think we need to do some of each. The potential for Medicare Advantage is to invite private plans to enroll Medicare beneficiaries, do things differently to get better results for both the beneficiaries and the program. Because of the way Medicare Advantage works, the way the prices are set, it has not fulfilled that potential. It's allowed private plans to enroll Medicare beneficiaries, essentially mimic traditional Medicare with all the same problems. So one of the reasons we believe Medicare Advantage reform is so important is to reward private plans that do it better.
Okay, so so in other words, they can't just continue on with business as usual. But Medicare Advantage, they should really be using these things for what it was designed to be, and that is really work at prevention, really working at care coordination. Am I correct on that? Okay. There's something else mentioned here. A point was made earlier, encouraging use of comparative effectiveness information in public reporting and provider quality, et cetera. This also relates to the issue of evidence-based medicine and evidence-based treatments that many people refer to. Throughout medicine, there's many branches that have their own standards and protocols. The College of Surgeons, American Academy of Pediatrics. Would those be things that Congress or the FDA or HHS could look towards in terms of what these standards might be, in terms of what is the best practices and what would be the standards and protocols to use?
Well, specialties are quite variable in how they develop those standards, those protocols. So it's difficult to generalize about them. Let me focus on the area of imaging as one example. We had as a witness before MedPAC, the president of the College of Cardiology, to talk about imaging issues. And one of the things that she called for was more information so they can move from just consensus-based guidelines to evidence-based guidelines. The potential and comparative effectiveness research is that we give physicians and societies the raw material to do a better job at what they want to do.
So, and this is a critically important point, and one that we should not rush at because it's going to have long-term implications. So the college cardiologists or radiologists or whatever that is, we have to make sure it isn't just they've all sat down and voted that this is what the best thing. But there really needs to be a demand, and this is where a valuable role government can have, the HHS or FDA to have oversight to say we want to see evidence-based medicine here. Is that what you're suggesting?
That's the goal. We need information for physicians as well as patients to guide that.
I mean, this is a critical thing, Mr. Chairman, and one I hope we continue dialogue on because it's going to be a factor that I think makes or breaks some of the budget is how we go through there. And I think also deal with the issue of who's making the decisions, and I think a valuable place where this committee can have tremendous oversight in working with medicine. And with that, I yield back. Thank you, sir.
Thank you, Mr. Murphy. Gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Mr. Hackbarth, welcome back to the subcommittee. I recall when you were here in March, we had quite a dialogue about, as we have today, about the difference between pilot projects and demonstration projects. And you expressed then, as you have here today, some hesitation about the administrative and regulatory burdens associated with demonstration projects and how that affects the ability to scale those up if they've proven successful. This draft healthcare reform legislation offers new pilot projects in accountable care organizations and medical home models. And I'm wondering if it's your sense that these pilots will provide us, the Congress, and MedPAC with sufficient evidence to make broader payment reforms. And also if you've examined these provisions in the draft, if you have any recommendations for further improvement.
Well, on the issue of pilots, we welcome the fact that the committee is looking at pilots. And what MedPAC has advocated, and we've talked about this before, is that Congress give the Secretary discretion to test a new payment method and to implement it if the pilot is successful. Establish goals in advance and then give the Secretary discretion, plus the resources necessary. And an important part of this, I think, is a much larger budget for the department to not just test ideas that come through the Congress, but to generate new ideas independently in the department. Right now, the demonstration budget's way too small for that.
In MedPAC's most recent reports, there's an interesting sidebar concerning the physician group practice demonstration, which serves really as a foundation for the accountable care organization pilot in the draft bill that we're looking at. You noted that a surprising number of the sites for the physician group practice demonstration project had high cost growth, and it's linked to the risk profiles of the patients at those sites. And it strikes me that basically there's an inference that these demonstration sites may be picking up more of their patients' medical issues, resulting in more treatments and increasing costs. What lessons do you suggest that we take from this demonstration?
Well, in setting payment rates for new payment systems like ACO, the details are very important in how the targets are set, how the potential gains are shared between the providers in the Medicare program, and how you adjust for things like risk, the risk profile of the patients. And so there are important steps that have to be taken from endorsement of a broad concept like ACOs to making it an operational, effective idea. And this is part of why we think the Secretary needs some flexibility and discretion in design and the resources to be able to do that quickly and effectively. On an idea like ACOs, we're unlikely to get it exactly right the first time. And so there needs to be ongoing cycles of refinement and improvement that requires discretion and resources.
And we can certainly relate to the difficulty to create a national program to rein in Medicare spending. And on the ACOs, the idea is to set spending targets to hold the providers accountable to the targets. If you tied spending targets to national averages, I guess I'd like to ask how are we going to attain or incent participation in higher cost areas? And do you have any ideas of how we would address that challenge?
Yeah, well, this goes back to the dialogue I had with Mr. Braley. One of the very important details in these new payment systems like ACOs is how you set those targets. If you take a group that has a very low historic level of utilization, they've been very efficient, very high quality, and say, okay, we're going to set your target at your historic level of costs, it's going to be more difficult for them to beat that and earn rewards than for a practice that's in a very high cost state and performing very poorly. That's not an equitable way to get to where we want to go. So setting that target rate so that you reward historic performance as well as future performance is, for me, a goal in the target setting. Now, in order to do that, you're going to have to squeeze someplace else. You're going to have to squeeze those high-cost places to offset the costs. So, again, the details in this are very, very important, and the Secretary needs to be given the latitude to strike that balance.
Thank you. Mr. Pitts is next.
Thank you, Mr. Chairman. Mr. Levinson, in your testimony, you mentioned Medicaid-specific services that are services unique to Medicaid that could lead to significant savings. And one example you cite is school-based health services. You say that OIG, quote, consistently found that schools had not adequately supported their Medicaid claims for school-based health services and identified almost $1 billion in improper Medicaid payments, end quote. Can you go into this further?
Mr. Pitts, we do make audit recommendations to the Centers for Medicare and Medicaid Services based on our audit findings as our auditors look at programs that are supported by the program. And that is an area that the OIG has identified over the last few years as one that CMS needs to focus on more clearly to make sure that those dollars are really spent appropriately.
Well, what were some examples of these improper payments? What was Medicaid paying for?
Well, overall, they were paying for those kinds of services that are not included in the program, but I would need to provide more detail to you as a follow-up to our hearing.
Now, the Bush administration proposed regulations which would stop these fraudulent services and stop wasting taxpayer dollars. However, the President administration has put a moratorium on these regulations. Do you believe that this moratorium should be lifted?
We do not comment on what the executive branch decides to do with those kinds of regulations or not. We certainly, advance what we believe would be appropriate ways of being able to account for the Medicare dollars better. And our recommendations are given in the first instance in these kinds of cases to the Centers for Medicare and Medicaid Services.
Do you have any idea how much money in total might have been wasted in this way?
Our audit findings will indicate the dollars that we believe are not appropriately spent under the Medicare program, and I don't have that dollar figure immediately at my fingertips. We'll certainly provide as much detail as we can based on the audit findings we already have.
All right. In your testimony, you mentioned the creation of the Healthcare Fraud Prevention and Enforcement Action Team. Can you give me some examples of what cases this team is currently addressing?
Well, the most recent example would be the case that was publicized yesterday in Detroit, a Medicare infusion drug fraud case that has resulted in 53 indictments. There have been 40 arrests so far. 40 of our agents have been involved in what is claimed as $50 million in false claims. This is a strike team in which we're working with the FBI and local law enforcement to clean up a significant Medicare infusion drug problem that now infects the city of Detroit. Some of these issues have actually migrated from South Florida. So the strike force effort is to try to provide both national and regional focus on those kinds of frauds that not only tend to plague particular cities in the country, but that also have regional impact. We already have strike forces in operation in a number of cities, but the effort now will be to extend that to more cities over the course of the next year.
Mr. Chairman, I don't know.
You want the time? The time? You have a minute left.
1 minute left?
Yeah. I'm sorry.
How do you get the provider ID number? The criminals get the provider ID numbers?
Well, obviously through a variety of fraudulent means, but it's too easy at this point in our system to get provider numbers, and that has been a constant theme of our office over the years, that enrollment standards have not been sufficiently rigorous to ensure that we're not allowing, in effect, criminals to masquerade as healthcare providers. Mm-hmm. And that has been a significant problem, not just in Detroit and Miami, but really throughout the country. And one of the key principles we have in terms of our anti-fraud fighting effort is to make more rigorous who actually gets in the program, because historically there's been too much of a right to access as opposed to the privilege of actually being enrolled in the program.
Mr. Boyer wants to follow up.
I guess we want to be responsive here. How are they relying on insiders within the system to get these ID numbers, or you don't want to tell us so that others will know how to? I mean, you can tell us offline.
Mr. Boyer, let him answer the question, but the time has expired. I have to apologize. The electronics have gone off again, so I'm going to just have to tell everybody when their 5 minutes is up. But go ahead and answer your question.
Thank you. I think it probably would be better to have an offline conversation, because the schemes are varied and some of them are rather sophisticated, and it's probably better not to discuss in any detail what actually occurs in a public hearing.
Thank you, Mr. Chairman.
Thank you. Next is Ms. Eshoo, and I'll just tell you when the 5 minutes are up.
Thank you, Mr. Chairman. Gentlemen, thank you for your testimony today, and to the chairman for this series of hearings with many, many panels this week. As we look to reshape America's healthcare system, we have very clear goals that we have set down. We want it to be universal. It needs to be affordable. We think that choice is important. We believe that many of the rules that need to be rewritten, that the insurers, the private insurers employ amongst them, knocking people out because they have pre-existing conditions and gender-based issues, et cetera, et cetera. So that's on the kind of on the one side of the ledger. The other side of the ledger, in my view, are two major issues. One, that we be able to achieve this without raising taxes. And number two, maybe I should have said number one. Number one, that we reform Medicare and strengthen it. We've read the report of the trustees. We know that they shaved off 2 years, and that we've got until 2017. 2017, believe it or not, is not that, it sounds like it's another century away. It's a handful of years away. So my question to both of you is, what are the large ticket items that you can name today for us that will strengthen Medicare? Now, Mr. Levinson, I recall a hearing here many, many years ago on waste, fraud, and abuse, and what essentially the private sector ripping off the public sector. And you've touched on that today. In fact, we had testimony from someone whose case had been adjudicated, and he was on his way to prison. And he came here and explained how he had ripped Medicare off. And it was essentially the private sector ripping off the public sector. So what are the price tags that you can tell us about in these efforts that will save us money, save Medicare money, and overall strengthen Medicare as we come through this large effort, this overall effort to reform our nation's health care system? Because I believe if we don't reform and strengthen Medicare, that we will not have accomplished what needs to be accomplished.
Let me go first. I would name 4 things. One is that we need to continue to apply pressure under the existing payment systems in Medicare.
Can you speak a little louder, please? Can you speak just a little louder?
We need to continue to apply pressure to the update factors in the existing payment systems.
And what is that going to? What do you think that's going to save us?
Well, you know, it depends on exactly what the levels are, but it's, you know.
Has MedPAC done that work?
Well, the CBO does the estimates of the budget impact of different recommendations.
Do you have any idea what that might be?
You know, again, it depends on the specific level, but tens of billions or more over a 10-year horizon. A second area that I mentioned is Medicare Advantage. There, as I think you know, the CBO estimate is higher than $150 billion over 10 years. A third area that I'd mention is readmissions, excess readmissions. And off the top of my head, I don't know what the estimate is for that, but there was a proposal in President Obama's budget on that, and it's a fairly significant number. Then the fourth area that I'd emphasize is shoring up primary care. Now, that doesn't lead to direct savings, but I mention it here because if we allow things to go as they are right now, our primary care base is going to continue to erode away.
That you spoke to that earlier, so I appreciate that.
Big money.
Mr. Levinson?
Yes, Ms. Eshoo.
And thank you for your wonderful work as IG. We really can't function well and do oversight without the IGs, and I just think that you all should be canonized. So.
Well, on behalf of 1,600.
Be interesting to have a Levinson canonized, right? Yeah. I'm pretty ecumenical, though, so.
Well, it so happens that, of course, Dante was talking about fraud 700 years ago.
Right.
So it's an issue that is both timely and, and has a long and very troublesome pedigree. But on behalf of 1,600 very dedicated auditors and evaluators, investigators, and lawyers, thank you so much. In just one, as I look at some of the recommendations that are in our compendium of unimplemented recommendations, our auditors estimate that we could, the program could save $3.2 billion over 5 years if we just limited the rental time for oxygen equipment. I mean, I think that there are specific areas where there are significant savings that can be had. As I look at just our most recent semi-annual report, in terms of monies returned to the Treasury, we're expecting just in the first 6 months of the fiscal year, $275 million in audit receivables and $2.2 billion in investigative receivables. A lot of that has to do with pharmaceutical cases. Pharmaceutical pricing, of course, is a very significant area that can also, if properly addressed, can save significant dollars. It would be hard to come up with total figures on a list of top 10, but certainly pharmaceuticals, DME, getting the dish payments right. We think that it is important to clarify exactly what Medicare should be paying for the Medicare and the Medicaid dish payments and how the states handle those dollars. We need to avoid gaming the federal dollar so that it's clear, it's transparent about who is actually paying for what and how the states account for the dollars that come from Washington. I would hesitate to put a dollar savings on it, but I think that there is a great need for much more significant transparency and accountability in our programs, and that is a very helpful trend from the standpoint of our office.
Do I have any time left, Mr. Chairman?
No, I'm trying not to
Okay. Thank you
interrupt
very
it
much.
now.
Thank you.
Sure. Next is gentlewoman from Illinois, Ms. Schakowsky. I'm going to just tell everybody when the 5 minutes are up, just so you know. Thanks.
Mr. Levinson, one of the biggest single expenditures out of Medicaid is for long-term nursing home care. And I've been working with Chairman Waxman and Chairman Stark on a nursing home quality and transparency legislation, which has been included in the draft bill. And I'd like to know what you have found in terms of problems with nursing homes that would necessitate more transparency and oversight of them.
Yes, Congresswoman, it's been difficult actually to find out who makes the decisions when we investigate substandard care in nursing homes and try to locate exactly who financially is in charge. So I think the effort to create greater transparency in terms of ownership, in terms of management, and get a clear understanding of actually who is in charge would help our investigators and lawyers significantly in being able to both investigate and resolve some of the very serious quality of care cases that have emerged in the nursing home area.
We're going to hear some testimony a bit later that disparages the notion that there is any substantial fraud or wasteful spending on the part of some doctors that participate in the Medicare program. Would you agree with that assessment?
Well, I can only point to individual cases that we've actually worked on. We try not to generalize. Our investigators and auditors are very focused, very anchored on particular instances when it comes to either individual venues or a larger corporate structure. And we do have an existing and unfortunately a growing caseload, workload.
Let me ask this though. Would you say that some may be fraudulent, some may be wasteful, but that in general the decisions about utilization are provider-driven as opposed to the kind of fraud or wasteful spending that's generated by individuals in the program?
You know, I would hesitate again to make any kind of generalizations because these individual cases are very much focused on the facts as we find them. But there are certainly cases in which we have found that we are frustrated in our ability to actually understand who makes the decisions in the nursing home chain.
Let me ask Mr. Hackbarth about the Medicare Advantage plans. it's great that in the Medicare program, consumers can actually go online and find out what Medicare pays for health care services. To your knowledge, is there a place where consumers can actually access rates that Medicare Advantage plans pay providers or other private insurers?
The actual payment rates for providers, not to my knowledge. I think most private plans consider that information proprietary business information.
In your view, will Medicare Advantage plans remain in the market if we eliminate overpayments?
I believe that they will, many will. Some will leave the market because they have a model that can't compete with traditional Medicare. But as I said earlier, we'd be sending an important market signal about the type of plan we want to participate. We want plans that can help us improve the efficiency of the system, not plans that just add more cost to the system. And when you send that signal, I believe in the market. I believe that we'll get more plans that can compete effectively with traditional Medicare.
What mechanisms will we need to ensure that Medicare Advantage plans and private insurers in the exchange meet a minimum loss requirement, a minimum loss ratio requirement?
Yeah. The minimum loss ratio, I think, it's a tricky issue. As you may know, I used to work for Harvard Community Health Plan, Harvard Pilgrim Healthcare, two very well-regarded HMOs. And this was a big issue for us sometimes with employers, how you calculate loss ratios. Our piece of the organization, the one I ran, is an integrated prepaid group practice. And we have a lot of clinical programs that we believe improve patient care that sometimes employers wanted to characterize not as medical care, but administrative cost. So that works against you in terms of calculating the loss ratio. So the details of this can be pretty tricky in my personal experience. So I'm always a little uneasy about just having simple rules on loss ratios. How you define those loss ratios is very, very important.
Thank you.
The time has expired. I'm sorry. Thank you. And next is the gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. Thank you all. I got a couple of quick questions at the outset. Mr. Levinson, you talked about trying to step up efforts to curb some of the fraud. In particular, you talked about, in response to one question, the application process for new provider numbers and having that vet properly. Have resources been an issue in terms of the capacity of those people that do the processing and the review? Has the resource in terms of the number of folks that can do that been an issue or not an issue?
Well, that's an important question, Mr. Sarbanes, that in the first instance I think needs to be addressed and responded to by CMS, which is the agency that runs the program. And as an office that looks to see where the vulnerabilities, where the weaknesses are in the administration of a program, we have identified for some years now that enrollment standards are too lax, especially in specific areas of vulnerability like DME. And whether or not there are resource issues, we find too many of the wrong kinds of people are getting into the program. And therefore, we have recommended over the course of the last few years that enrollment standards be strengthened.
Well, I'd imagine, I mean, I used to do some of that work, and I would imagine that the best way to vet it on the front end is with a little more intensity of resources applied to actually going out and finding out who's behind these applications that are being filed. Let me shift gears. I was really intrigued by the discussion on the school-based health centers and some of the findings of fraud. In that discussion, there was a there was an allusion to the possibility that that there was services being, that reimbursement was being sought for services that were not actually provided, but possibly there were other services being provided that one might view as important services. They just aren't services that Medicare or Medicaid reimburses. And I wanted to ask the question of whether this phenomenon, and this is, in my view, the problem, is whether you're talking about fee-for-service or you're talking about capitation. Either one of those can work okay if you're paying for quality as opposed to paying for quantity, and if you're paying for the right things as opposed to not paying for the right things. But maybe both of you could comment on whether the potential for fraud is greater when you have a system that pays for quantity versus quality, or is paying for the wrong things. And while I don't want to excuse fraud, if somebody is trying to find some payment for what they view as a very important service that is not covered under Medicare or Medicaid, that's a different kind of impulse than seeking to get paid for a service that's not being provided at all. And it seems to me the way the system is structured right now, and it is so distorted, that it leads to that kind of thing, because people say, this service is valuable, but Medicare won't pay me for it. And if we can move in a direction where we're paying smarter for things that make a difference, we might actually make some progress on this fraud issue. So maybe you could each respond.
Well, I do think the facts that you've laid out, Mr. Sarbanes, are important ones to focus on. The notion that there can be monies spent that are just not appropriately covered by the program. And in many instances, we're really not talking about fraud in terms of the legal definition of fraud. We're talking, though, about dollars that Congress, that the program says should be directed in a particular way, and our audit people, not our criminal investigators, find have not been spent appropriately, and then we make the appropriate findings and recommendations to CMS. Not all of our recommendations are acted upon by CMS. There unquestionably are judgments. Perhaps some of the kinds of judgments you're talking about here are the judgments that programmatically are made by CMS over the course of looking at our recommendations, because just by the fact that we make those recommendations doesn't necessarily mean that the dollars will actually be collected. And I do think that it is important to distinguish between those who have an intent to take advantage of the program and those who, unfortunately, are simply not paying appropriate attention to our rules. But of course, given the precious resources, we take the rules set by Congress and the Department seriously, and we report accordingly.
And the time has expired. I'm sorry. Next is Ms. Daggett.
Thank you very much, Mr. Chairman, and thanks to this committee. I know you've discussed some of the issues in general that I want to talk about, but I'd like to hone in on them a little more. My first question is you talked about, actually, Mr. Hackbarth, the MedPAC has talked about changing the Medicare payment system incentives by basing a portion of provider payment on quality of care. And to do this, Congress could establish a quality incentive payment policy for physicians and other plans, Medicare Advantage plans, healthcare facilities. I'm wondering if you have some specific recommendations you can make as to what kind of quality measures people would have to include to be, or to develop to be included in a quality incentive payment policy.
Well, let me focus on a few different areas of the program. For example, in the Medicare Advantage program, we've long advocated that a piece of the payment be adjusted to reflect the quality. And there are
But how do you do that?
There are well-established industry measures developed by NCQA that private employers use to assess health plans. We believe Medicare should be doing the same and adjusting payment accordingly. In the case of dialysis services, again, there's a pretty strong consensus about what the critical quality measures are. We've advocated that the dialysis payments be adjusted to reflect those outcomes for patients. Likewise, in hospitals, we think there are some strong consensus measures. In fact, Medicare requires, as you know, specific measures be reported. We'd like to see payment linked to that.
Do you think that the current, and I do know that because my heroine, Patty Gabot from Denver Health, is here on the next panel, but do you think that we could, do you think that this quality measures that we have in place now are sufficient as we move forward with comprehensive health care plan? Do we need some kind of additional mechanism? Do we need additional quality measures? What do we need to do?
I think that the measures need to evolve over time. I think we've got starter sets, if you will, for a lot of providers, but we need to invest in developing them in the long term.
And who should do that?
Well, Congress has invested some money now in NQF, the National Quality Forum, which I think is a wise investment to build infrastructure for ongoing improvement in quality measures.
And do you think some of these quality measures that you talk about for Medicare Advantage can also be used for physicians and other types of health care facilities like hospitals and community health facilities?
Well, each provider group presents its own challenges and will require unique measures. I mentioned 3 areas: Medicare Advantage, ESRD, and hospitals, where I think there's a pretty strong consensus on starter set of measures. Other areas are more challenging. Physicians are more challenging just because of the nature of medical practice. You often have small groups or even solo physicians, so not a lot of numbers to do measurement.
But you know what, though, people like Geisinger and Kaiser and others have been able to develop quality measures for doctors that it would seem to me you could develop. And if you don't develop those for physicians, then it's hard to see how you can get the improvement in medical care at the same time that you get the cost containment in our system.
And I agree with that we do have initial measures. They're not comprehensive measures for physicians. They tend to be very focused process measures.
Right.
I think we can do a better job in assessing physician performance as we move to bundled payment systems where we get groups of physicians working together. We can start to measure outcomes, not just
That was my next question. To develop those measures, again, what kind of mechanism do you think, would it be the same one you talked about, that Congress, there's a group of us, Senator Whitehouse and myself and others, who are very concerned that if we don't develop quality measures throughout the system, that we're really not going to have improvements in patient outcomes.
So we need a process for forging consensus and establishing a set of measures.
Right.
You don't want 12 different ones.
Right.
And everybody using different measures.
Right.
That's a burden on providers.
Right.
And NQF can be that process. It can grow into that process where we have consensus. Then we also have to invest in the research about what works. That's where comparative effectiveness comes in. That can provide raw material for specialty societies and the like to develop guidelines on what constitutes good care. And that can also feed ultimately into the assessment process.
Great. Thank you. Thank you, Mr. Chairman.
Thank you. Gentleman from Texas, Mr. Gonzalez.
Thank you very much, Mr. Chairman. This will go to the chairman. There are 2 major components of what we're considering, and the experience gleaned from Medicare is going to be used either by the proponents or the opponents. Just again, it'll be the performance of Medicare in the eye of the beholder. One is the public option, the other is the health insurance exchange. So I'm going to pose a couple of questions and then just let you respond, in that way it'll be the chairman that will be advising you that my 5 minutes are over. But first, I haven't met with a group of doctors in San Antonio yet that have agreed with the compensation adequacy. And what they're all saying is that you guys are basically working with stale data and information, that it's at least 2 years behind the times of what modern medicine and its practice entails. That's the first question, and I know that we touched on it more or less, but that is going to be very, very important as we go out there with a broader plan that, again, has something that will mimic what we've been doing under Medicare. So that's the first complaint that we get. My colleague, Ms. DeGette, also touched on something, and that was, how do you establish proper protocols? What is acceptable, best practices and standards? On the Small Business Committee, we had Governor Pawlenty, who came up, and I asked him that because my doctors asked the same thing. Different patient populations may dictate different practices and such. Well, Governor Pawlenty told me, he says, we got Mayo, they established the standards pretty much, and no one's going to argue with them. The question to you is, how do we ever really achieve nationwide standards that may address diverse populations and such? The last question is a somewhat interesting one because it presents a real dilemma for me back home. Texas has probably the greatest number of specialty hospitals. The question really is how is modern medicine being delivered in this country, and to keep up with that. There are portions of this bill that would discourage, of course, specialty hospitals. Yet we are looking at what we refer to as bundling, and that is more centralization, more coordination, medical home, all that entails. But in essence, isn't that what specialty hospitals and many of these specialty practices provide? And that is, when a patient goes into those settings, that there are many different services that are being provided within that environment that otherwise would be separated out to different locales, offices, and other doctors. And we even have different specialists that argue among themselves as to what extent they should be able to do that. And I would just like your views on those 3 points. And again, thank you for your service.
Okay. That's a lot of ground to cover in just a minute or two. Starting with the stale data, I imagine what your physician constituents are referring to as Medicare claims data, which in fact is a couple years old by the time it's used in the policy process. That is a problem. That's an area where I think some wise investments in Medicare infrastructure would pay dividends. I'm not sure, however, that the age of the data would alter any of the recommendations we're talking about for reforming the payment system. With regard to standard setting, I do believe it's very important to have a process that is coherent and credible from the perspective of providers. I fear that sometimes we have an embarrassment of riches. We have a lot of different people saying this is what constitutes quality of care. Some of it's founded in research. Other pieces of it are not. If we want to send clear, consistent signals to providers, not just from Medicare, but from private insurers as well, we need to have a coherent standard-setting process. As I said a minute ago, Congress, I think wisely, has invested some money in NQF to start building that infrastructure. On the last issue of specialty hospitals, roughly 2 years ago now, MedPAC, at Congress's request, invested a lot of effort in analyzing specialty hospitals. Our basic findings were that when physician-owned specialty hospitals entered a market, costs tended to increase, not decrease. More procedures were done. The evidence on the quality of care there was not definitive evidence one way or the other that was better or worse. It seemed to be about the same. At the time we did our analysis, our big concern, our immediate concern, was that at least some physician-owned specialty hospitals were exploiting flaws in the Medicare payment system. They were focused on procedures where the Medicare rates were too high. We made recommendations which Congress adopted and CMS is now largely implemented to change payment rates so there aren't those gaping opportunities to exploit the system.
Thank you. Mr. Matheson is next.
Thank you, Mr. Chairman. I'm sorry I was not able to be here for all your testimony, but I do appreciate your coming before the committee today. The question I wanted to raise is, you know, MedPAC has had the opportunity to make a lot of recommendations about how we can achieve greater efficiencies or greater value or good practices. And often, in terms when it comes to implementation, Congress is not necessarily followed through on that. Do you have suggestions for if there'd be a better structure to help assist in allowing these recommendations to be implemented in a more effective way?
Well, you know, one of my themes this morning has been that I think the Secretary of Health and Human Services and CMS need both more discretion and more resources. So they need the flexibility to refine, change payment systems over time to achieve goals established by the Congress. For every small change to have to come back through the legislative process is a very cumbersome process, and it makes progress very slow. And I'm not sure that's a luxury we can afford at this point. So more discretion and more resources for the department would be my first recommendation.
Do you have, in terms of making that recommendation, is there a specific proposal about what the resource needs might be, or is that something that we can look to maybe get some information from you all?
Yeah, I would urge you to go to the department for that information. They're the best judges of exactly what they need.
Do you feel like the way MedPAC is structured right now that you are adequately insulated from having members of Congress come in and tell you, here's what we think you really ought to be doing?
Well, we welcome our exchange with members of Congress, and the MedPAC staff works very closely with both the committee and personal staffs to understand congressional perspective. I have never felt undue pressure from any member of Congress.
You feel like you're adequately structured to be an independent entity? I guess that's what I'm asking.
Yeah.
Okay. Thanks, Mr. Chairman. That'll be it for me.
Thank you. Mr. Barrow?
Thank you, Mr. Chairman, and thank you, gentlemen, for being here today. I, too, along with Jim, had several other meetings this morning, so I apologize for being a little late, but I'm glad to have the chance to visit with you, and thank you for coming and offering your testimony. You know, fixing what's broke with Medicare Part D is a large part of comprehensive health care reform, and a lot of attention has been given to ways and means of trying to plug the donut hole, among other things. I want to focus on a problem with the Medicare Part D program that has bedeviled the people that I represent, that I hear about at every one of my town hall meetings. And that's the excessive degree of discretion and variety in the formularies that all of these various for-profit insurers are paid by the public, essentially, to assume a public risk, and the incredible confusion. You know, there's such a thing as too much of a good thing. And if there's too much variety and choice in the marketplace, you have a hard time finding what you need, and you have to do a lot of hunting and trying to find the drug that you want. And then with the potential for bait and switch that can exist and formulary being changed on you out of money after you've signed up, that just makes things so much worse. My question to you is, and I guess Chairman Hackbarth, you're probably in the best position to answer this, is any thought being given, since this is a public finance plan to get the for-profit insurance industry to compete with each other to make money trying to offer a benefits package, to assume a public risk in providing this benefits package, any thought given to trying to make more, to have a centralized or more standardized formulary that is comprehensive in its scope, but provides all of the necessary flexibility and variety to allow doctors to opt out when there's a medical necessity that they know about, a generally good reason to do so. But to make it clear that when folks go into this very confusing marketplace with so many people competing for the customer's business, that they know when that they're comparing apples to apples, they know that the benefits package is substantially the same, just as the entity that's paying for this is substantially the same, just as what you hope to get is substantially the same. Is any effort being made to do that?
Well, you're absolutely right that the choices that Medicare beneficiaries face are complicated in choosing among plans because of, among other things, differences in formularies. I would also add that it doesn't stop with the beneficiaries. You know, differences in formularies also have a significant impact on practicing physicians and how they deal with individual patients. What they prescribe needs to vary according to the plan that the patient is covered by, and that can be a real problem for physicians. There's a trade-off here, though. The flexibility around formularies and the exact benefit structure, those are tools that private plans can use to try to offer a better value for Medicare beneficiaries. Those are the tools that they can use to reduce the cost of the plan. And so there's a trade-off to be made. There's not
if you have a plan that's designed to the health profile of the patient, in theory, you can get yourself into a much smaller risk pool and be shopping for something that's just tailored for you. But the point is, it loses the quality of being insurance and it takes on the quality of being sort of a revolving loan program.
Yeah. And some people have expressed concern in particular about specialty drugs, very high-cost drugs for patients with serious illnesses.
Well, if there's a medical necessity for that, the smaller the risk pool of folks buying into the program, the more expensive that's going to be when it is absolutely necessary to get it. So that sort of drives up the cost for those folks who need it when they need it. So what I'm getting at is if you really have too much choice, you don't know what you're choosing, and the other party on the other side of this deal can change the deal on you after you've signed up. We make this thing much more complicated, much less user-friendly than it has to be. And I want to make sure we're not driving up the cost by having exotic stuff driving up the cost for the ordinary everyday stuff. But there is a profile, there is a comprehensive scope of conditions that we can treat effectively, cost effectively with medication. And it seems to me the more we can eliminate the confusion in this, the more and make it genuinely available and comprehensive in its scope, the better service we're providing all our customers. Because after all, we're paying these folks to assume this public risk, and we ought to make sure that folks know what they're getting when they go into the marketplace.
Mm-hmm.
What is MedPAC doing about this? Are y'all looking into this?
Well, on the specific issue of the complexity, you know, we have looked at the choices that Medicare beneficiaries have to make in choosing among plans, and looked at the tools that beneficiaries have available to them. CMS does have some tools, as you know, to try to help beneficiaries compare plans and choices. We think here again, this is another area where some investment could pay dividends in helping beneficiaries understand their choices. There's no way around, though, the ultimate trade-off that you're going to face between complexity on the one hand and flexibility for plans to manage the costs on the other.
Well,
there's no right answer on how to strike that balance.
I think doctors...
Time is expired, but if you want to say something.
I just think doctors ought to be able to make those calls. Thank you, Mr. Chairman.
Thank you. Unless anyone else has questions, we're going to proceed to the next panel. So thank you very much. Your input is obviously very important as we proceed on this, and appreciate your being here this morning. Thank you.